Position the patient supine on the operating table with a roll placed under the neck to extend the head. Induction anesthesia is started using mask ventilation. Rigid bronchoscopy is performed to localize the fistula, determine the grade of tracheomalacia, and to rule out a coexisting proximal fistula. The bronchoscope is introduced into the vallecula. The tube is advanced through the vocal cords and the tracheoesophageal fistula is identified. The carina and both main bronchi are visualized, and the distance from the carina to the fistula is measured. The trachea is intubated via the left nostril. This makes it possible to manipulate the replogal tube during the operation via the right nostril. The position of the uncuffed endotracheal tube is checked using a flexible endoscope. The tip of the tube should be in the trachea and lie distal to the fistula, provided there is sufficient length between the carina and the fistula opening. Next, move the patient to a left lateral decubitus position to allow access to the right hemithorax. An alternative is a semi-prone position with the right side elevated using a longitudinal roll. The right arm hangs loose with the right scapula in slight external rotation. Secure the patient to the table with straps across the pelvis and the head. Use a convective temperature management system to maintain normothermia. An electrosurgical grounding pad is placed on the abdomen. A double lumen replogal tube is introduced via the right nostril and advanced into the proximal esophageal pouch. Drape the patient and disinfect to create a sterile field extending from the spine to the sternum, exposing the right nipple as a landmark, and from the superior angle of the scapula to the level of the costal arch. Ensure that the left side of the table is clear and free of lines. This allows the surgeon and first surgical assistant to stand at the left of the patient. The second assistant and scrub practitioner stand at the right of the table. Monitors are placed at opposite sides, so the monitor for the surgeon and the first assistant is on the right of the table, and the monitor for the second assistant and scrub practitioner is at the left. Next, introduce the trocars. In this repair, 4 ports are used. One 5 mm camera port, 1 cm caudal to the inferior angle of the scapula, 1 3 mm port on the right, ventral to the scapula and lateral to the right nipple, and 2 3 mm ports on the left side. The position of the trocars in the lateral decubitus position is shown in this overview. Ensure that cannula tips are advanced deep in the thorax to reduce the risk of lung damage when changing instruments. Insufflate the pleural cavity to a pressure of 3 mm of mercury at a flow of between 1 and 2 liters per minute. Inspect the pleural cavity and identify the distal esophagus and the esophagus vein. Position the right lung medially. Open the parietal pleura using blunt dissection, starting approximately 2 cm caudal to the esophagus vein. Here, the right bronchus is highlighted. Dissect the esophagus at both sides, preserving the anterior and posterior vagus nerves. Continue to dissect both sides of the distal esophagus until the plane is confluent. Here the aorta is highlighted. Encircle the esophagus with a vessel loop. The second assistant then lifts the esophagus by grasping and retracting the vessel loop using a 3 mm instrument. Continue the dissection towards the esophagus vein. The anterior vagus nerve is highlighted here. Open the pleura cranial and caudal to the esophagus vein to create a tunnel running under the esophagus. Next, pass both ends of the esophageal vessel loop under the esophagus vein. This allows the esophagus to be lifted cranial of the vein, out of its bed. In this patient, the esophagus vein is preserved since the fistula with the esophagus is cranial to the vein. Continue the dissection cranially to expose the tracheoesophageal fistula and the trachea. Place one superficial stitch subadventitial to incorporate the join of the trachea and the fistula. Avoid transmural placement. Encircle the fistula and secure the suture using a suitable number of knots. Incise the fistula using scissors and divide about 3/4 of the diameter. Leave a cuff of about 3 to 6 mm of tissue at the tracheal side. Next, open the pleura cranially and continue the dissection to begin to expose the proximal esophageal pouch. Identify the proximal esophagus. This is aided by the anaesthetist applying gentle movement to the replogal tube in situ in the pouch. Bluntly dissect the proximal esophagus circumferentially, progressing in a caudal to cranial direction. Here, an additional 3 mm non-traumatic grasper is used to pull the blind end of the esophageal pouch caudal. Carefully dissect between the common wall of the proximal esophagus and the trachea to mobilize the proximal limb of the planned anastomosis. Now mobilized, open the proximal esophagus using scissors. Resect the blind end and remove the redundant tissue from the chest. Begin the anastomosis by placing an outside to inside stitch in the posterior wall of the proximal esophageal section using a resorbable 5.0 suture. Ensure that stitches incorporate sufficient mucosa, but bites are small enough not to involve too much of the muscularis. Place a second stitch through the corresponding wall of the distal esophageal section. Next, divide the fistula completely, completing the transection using scissors. Approximate the two ends of the anastomosis by throwing a square knot or sliding knot, depending on the distance between the two ends. Pull the knot slowly together to approximate the ends of the anastomosis, and secure the first suture with a suitable number of knots. The vessel loop is left in place to allow continued mobilization of the distal esophagus and help with forming the anastomosis. Place 3 to 4 sutures to form the posterior row of the anastomosis, making sure to incorporate mucosa in each bite. Next, remove the vessel loop. The remaining opening after completion of the posterior aspect of the anastomosis and the fistula remnant are shown in this highlight. Next, introduce a 6 French nasogastric tube and advance it along the proximal esophagus, through the anastomosis and into the efferent limb. Complete the anastomosis over the nasogastric tube by placing 3 to 4 interrupted sutures anteriorly. Finally, remove the trocars from the chest under direct vision. A chest tube is only left in situ in the event of specific complications.
If you enjoyed the video, don't forget to hit the like button, share it with a friend, and subscribe to our channel, Intuitive Surgeon. Thank you for watching.